when we do the work we do over here because we love it so much, we can make anything fun. But echo is a lot more fun when we get cases. And so that is why I wanted to do this today with you guys. And I'll be honest, I'm not surprised we don't have as many attendees today as we normally do, because we're not diving into one of our juicy topics related specifically to addiction medicine and the management of our patients. But it's part of echo that's a really, really important part. And I don't know, I don't think anybody enjoys hearing me beg or have radio silence. So that is my subtitle, How to Enjoy an Echo Without Begging or Radio Silence. Presenting a case is really a way to avoid both of those things, but also enrich the experience that we all have when we join an echo. For those of you who've been on a session when we've had a case to discuss, maybe I shouldn't say so, we often go over a little bit because the conversation gets really, it's turned on, people are excited, we're sharing, we're talking. And so today this is meant to kind of give a little bit of background to what echo is, how it came to be, and why the case presentation is such a central component of making echo as impactful, powerful, and fun as it can be. Because I'm going to make the case for why the case presentation, I'm making the case for the case, why we really need to have that as part of our echo. So I don't have any, and I'm not talking about medications, so no disclosures. So a little bit of the review, history of the echo. I've got to make this thing go away. There we go. So I can actually read my slides. History of echo, construction of an echo session, how it's put together, benefits of including case presentation, and then at the end, when you guys get your evaluation, please do it, because your evaluation test questions are actually these questions I have at the end, which are kind of brainstorming ideas, just kind of get your all's feedback. So even if you're kind of like, I am not piping up and telling them what I really think, do it on the evaluation, because I want to know where you guys are on the spectrum of this case presentation, how you're feeling about it, how queasy it makes you, or how, like, just where you are with it. So that will come at the end. So extending community health outcomes, echo. It's one of those things where when you think about echo, like echo and reverberations, right? It's a really cool name to call this thing that we do. And so I think they had echo as the idea for the word they wanted to use, and then they made other words match it to get the acronym. So extending community health outcomes is kind of like, what do you mean by that? I really think it was echo came first. The words to make echo came later. That is my assumption. I do not know the story behind how they came up with the name. But basically, when we in medical school and residencies, we do the medical rounds. And the way that, like, whether we have grand rounds, it's formal, or we're doing walking rounds, or whatever it looks like, just that repartee back and forth between the attending, the physician who's kind of leading the group and providing supervision and is kind of in charge of patient care. But there's care being provided by the residents or the medical students, that dialogue that happens between those individuals of that group, and we all learn from each other, right? Maybe you're in a residency program and you've got 3 people on your inpatient team, and they all 3 came from different medical schools, and then you've got your attending who's got 20 years worth of experience, and just putting all of that together. At your institution where you trained, you guys did this was the protocol you guys used, somebody else had a slightly different one, and then everybody walks away from that discussion, those rounds, with more understanding, more tricks up their sleeve, and just because of that sharing that you did, more sense of a community, that you're part of something bigger than just yourself. So that's what echo, the idea of bringing people together kind of in a round table discussion, how that came about. So the learning framework, applying it across disciplines, and not just that rounding team in the hospital or a team within a clinic, using that concept though and applying it in this virtual format, because as you guys all know, echo, we were doing this before we had a pandemic, and echo as an entity and providing these training and learning opportunities existed in the early 2000s. So it's been around for a while, this model. And at the core of it is all teach, all learn. One of the reasons why we do this when we do the introductions, you'll see I have an anatomy breakdown here in a second of how it's put together. the ECHO I was a participant on, they very much did it in like the hub team members would introduce after the participants. So you kind of got a clear sense of who is hub team, like the experts, so-called, and the participants. Here we just like, so I can keep up with the boxes and make certain I get everybody, I just read across. So you get a mishmash of hub team member, participant, hub team member, participant, participant. But the idea is we also use each other's first names too, like it's not Dr. Troxler. And the reason why it's not that is I'm Joyce, I'm here to learn from the people in the room with me, from the people on my screen. Maybe you guys learn something from me, from something I say. So we all teach and we all learn. It's an equal exchange of information and knowledge and experience. So this virtual community, peers, where we share support, guidance, and feedback. One of the things I really remember that just why I love the ECHO that I was a participant in so much was, okay, confession time. Someone would present a case and I should be like, are you serious? This is the case they're presenting. This is simple. Like, why are they presenting this case? And that might be part of why you guys are like, I'm not presenting a case, because somebody in the room is going to be like, why are they presenting this case? We feel that resistance, right? Of like, I don't want to put myself out there because I don't want to be judged. And so after a couple of times of my little like, I know all of this, why are they presenting this? And the people would have questions, or the hub team members would have suggestions or a whole new idea. And I'm like, that was a lot more complicated than first blush. Like that was some really cool stuff I'd never even thought about. So that all teach, all learn model, like everybody takes something away from it. And it may not even be anything related to direct patient care that you walk away from, but you learn about a new resource, or you learn about, I don't know, maybe a different way to conceptualize or speak about, or some ideas. You're like, oh, that totally generated a different idea in my head that I could use with a patient, that if I had not had this experience of engaging with peers and seeing how they do this, I wouldn't have had this great idea to share with my patient. But also just like the work we do is hard, right? So just seeing each other support one another, and like, I'm so happy you're here. I'm so happy that you care so much for your patients, and they're so lucky to have you. You're like, that's right, I'm doing an awesome job. So it really, it buoys your enthusiasm for the work you're doing, because sometimes that can flag because the work that we do is hard. So the community that we grow and develop through ECHO and sharing our cases with one another, it really helps make that happen in a palpable way. So the collective understanding of how to disseminate and implement our best practices continues to improve and expand. And the fact that we have members from the treatment community that include more than physicians, because ECHO started very much physician to physician. But in this interdisciplinary model that we use, and a number of ECHOs use as well, we're getting perspectives from others that we may not have in our own clinic. And that can really improve our understanding and our ability to possibly incorporate or make a case for bringing in other team members that we don't currently have, or ways in which we know that we can connect with other members of our community to pull in services we may not be able to offer ourselves. So Sanjeev Arora is the one who got this all started. And this, I think it was in the 90s when he was having this experience. He's up in Albuquerque, New Mexico. Albuquerque, New Mexico, where they have University of New Mexico, is the academic medical center for the entire state, and even some of the surrounding states. So the other communities don't have hepatologists. They just don't. There's a lot of rural areas. People are widespread in New Mexico. And he was getting patients 8, 12, 18 months after their initial referral had been placed, because his clinic was busting at the seams. So somebody might be scheduled in 8 months' time from the original referral. They didn't have transportation to get there because they don't have the gas money. The car that they have access to is a beater, and they have to reschedule 5 times before they get up there. And by the time they get up there, a very treatable condition, their hepatitis C, is now so advanced that, as in this particular case, he was not able to do anything to change this individual's course. And she passed as a result of her hepatitis C, untimely and with orphans, right, in the wake. So he's like, this has got to stop. There's got to be a better way of doing this. And that's how he came up with the ECHO model, and that all teach, all learn. So he just basically, with hepatitis C, started reaching out to remote rural underserved communities in New Mexico and teaching the providers in those communities how to treat hepatitis C. And it grew from hepatitis C to chronic pain to high risk OB, like just a number of different topics that, not getting care in your community could really impact the outcome of your condition. And it spread from New Mexico to other states and then all around the world. When you are wanting to launch an echo, you have to go and do a training, like an immersive training. And when you go to your immersive training, you're like, there are people from Africa in the room with me. There's a group from Australia. People from all around the world descend on Albuquerque, New Mexico to get this training so they can take it back and start disseminating information and sharing best care practices in their communities. So amplification, the technology we use, like Zoom, again, like I said, way before pandemic. Zoom, actually, part of the reason why Zoom is as successful as they are in being in this space is because of a very early connection they made to Echo. When we first signed up, Zoom really wanted to get themselves out there. We had a free, we have it other ways now, but our Zoom account was free. So if you were doing Echo, you had free access to Zoom. So they wanted to make the technology accessible. They wanted it to not be a barrier, so it was free. So that's how you kind of leverage that technology piece and getting it into scarce areas. So with some of the remote communities in Africa, I can't remember exactly where in my group, there were some people from Malawi. I can't remember where they were from in Africa, but like they were talking about the technology they would use and just showing like kind of the smartphones that they had, and they would have them, there would be a little community center where there would be like people from other communities would come to share that one smartphone. So you can totally do this without this big computer screen that I have to do it. You can be smartphone to smartphone to get this done. And when you engage in disseminating best practices, evidence-based care, it reduces the disparity. So this gets at that idea like healthcare shouldn't depend on your zip code. We all know that it does, but by using Echo, it helps to reduce that disparity and improve care regardless of your zip code. Case-based learning helps you master that complexity. So, we can come up with cases, from our clinic, but that's just a thin ribbon of what is out there and what people are experiencing, which is why it's so important for you guys who join us to actually share what you're seeing in your community, because the resources may be completely different than what we have and are able to utilize here. You may, because nothing other than need is the best proponent for being, words are escaping right now. Like basically, like the need to be intuitive is not the word. Ingenuity, that's the word. Need is a prime pusher for ingenuity. And when you have a need and you don't know how to address it and you just have to get creative, you may come up with a solution for your problem, which is applicable across way more territory than what you think it is. And bringing those cases, things you don't even realize are really cool, just because need has caused you to address it in this way. Somebody may be able to take that and do amazing things with it in their community, just like you've done in yours. So even though you think something you're doing may not be that amazing, you bring it to a place like this, and one, you're going to get props for all the hard work you're doing and how amazed we are with what you're doing and the care and concern you have for your patients. But you may also be making everybody else's job easier because you really stumbled onto something that is applicable on a much wider scale than what you're doing in your own community. So bringing that is greatly appreciated by those of us who are on the receiving end. The data piece, the monitoring outcomes to increase increase impact. So whenever you guys attend, there's like it's like Big Brother watching you. There's a program in the background that is actually collecting the data, like what are the disciplines of the people who attend, where are they coming from, as far as like, when we have people from New York or Memphis, Mountain City, it's able to kind of show the reach of our impact. And that data actually goes to Albuquerque, where they use this information to help push grant funding, increase their scope, increase their range. So by showing up and attending, you are actually helping ECHO further the cause. And it's even part of legislation where they've been able to go to state and some federal to get financial support based off of the data that they draw from us just having our ECHO every 2 weeks. So by participating in ECHO programs, a single specialist, so just one of you guys, can contribute to the development of 20 or more local experts. So that multiplier effect, what you pick up here, what you carry back out into your communities, the people you talk to, some of the information that you share, whether you're like, I learned this in ECHO, that part isn't what I'm talking about. It's just if you learn something or pick up an idea or a new resource because you attended, there's the potential to impact 20 other local experts with what you've learned in one of these ECHOs. So by attending, you're increasing the knowledge base of your community, period, each and every time that you show up. So I alluded to this a minute ago, the anatomy of an ECHO. Like I said, like this is the boilerplate they give us. Some people really like, to the letter. I follow this with my facilitation fairly closely. So I've sat in on some ECHOs where it's like, have they ever seen the anatomy of an ECHO? Like, what are they doing right now? So there's a lot of fluidity with what happens within an ECHO, but going through the introductions, that kind of helps impart that sense of community, that we all belong. Any announcements or updates, like when Melissa gives us, like, this is how you claim your credit. We give our talk. Some people like to do the presentation first and then they do the didactic. We do ours first. The patient presentation, and then the back and forth. So we haven't gotten to have that many case presentations, but typically what happens is the presenter tells the case. I will summarize it as the facilitator and then kind of get clarification questions first, like any other, what else do you want to know about the case? And then we'll move into any recommendations or impressions for the case. And sometimes it'll be like participants first, and then the hub team members will say, what they think or need their clarifying questions. And then to give participants a chance to speak up first before the experts have a turn to give their recommendations, because you get the expert to say like, well, I'll do this and this, and then everybody who's a participant's like, yeah, that's totally what I was going to say. So it's nice to have participants provide their thoughts first, and then kind of cap it off with any information that the hub team members would like to share. So that's the basic flow of what an ECHO would look like when you get a case in it. So somebody did go and look in the University of Nevada, I think, like, what do you guys think about the case presentations? Like, would you like a training on how to do that? So looking over that data, when I was like, I want to do something on case presentation, and somebody else looked at this and done something, this is what I found from Nevada. And in the survey, they found that there's a fair amount of apprehension and anxiety about presenting an ECHO case. And I'll tell you, when I presented mine, it was, oh, so the patient is a 27-year-old. Like, it is nerve-wracking. But after, the second or third one that I had presented, just because everybody was so welcoming and encouraging of my case and what I was doing, and gave me some really great ideas, that, I went on and presented several more after that. So it gets easier with time. I'll tell you that much. It gets easier with time. Each one you do, you feel more comfortable about. And then we thrive on this case-based learning because, as I've already talked about, just the complexity that it gives, the opportunity for people to learn, and building of community, and also just give you that feedback of, we really appreciate the work that you're doing. It serves multiple points in bringing this hour to life for you guys. So selecting your case. Okay, we've already gone through like why it's important to have it, recognizing it can be a nerve-wracking process to do this. If you've ever seen a patient or a client that has active or history of substance use disorder, or you have a question or a shareable moment about caring for that individual, yes to either of those questions, doesn't even have to be both, you have a case. It's really great to be like, I did this thing, I was just winging it, and it really worked. And then I did it with a few other people. It wasn't just a fluke. You want to share that with us? We'd love to hear it. I thought this would work. It didn't. I want to kind of figure out maybe where I went wrong or where this might be useful, because it seems like it would be a good thing to do. I got these test results back and they seem really wacky, and I'd like some help interpreting them. So many other things I haven't even put on this slide. This is meant to just be like, you're here, so obviously you have an interest in addiction medicine and patients who have substance use disorder, which means that maybe you've seen a patient or a client who has substance use disorder. That is a case you can present. You can share with us your experience with that patient, and we can discuss it across the entire group, and everybody's going to walk away from it with a good feeling of glad I shared, so glad that person shared. I feel like I can do this too. I really learned something today. I didn't expect it to go that way. So these cases really just amp up what it's like to participate in ECHO. This is our webpage. I am not that adept in flipping back and forth in screens, but this is the hyperlink for it, which I'm not going to click on. Basically, if you guys just ETSU, I am ECHO, put it in your Google browser, you will find our webpage. We pop up very first on that. And with that, you'll be able to look at our page and see how it's put together. So the very first thing I have here, I'm not going to the page. So this would be something that if you guys want to give us feedback about our webpage, I'd love to hear it. Do you find it easy to navigate? Are you able to find the information? Like when I talk about in our sessions that Rick will, the citations that he's put in there, the links to the articles, we pull that and put it under our resource section. Have any of you guys gone and looked for that? Have you been able to find it easily? What do you like or dislike about our case submission form? There's a link that you can click on that. And if you look at the case submission form, you're just like, this feels overwhelming, or this feels like I want to tell you more, but you're not asking for it. Is there a place for me to put that? So giving us feedback on our case submission form, and then anything else you see about the webpage that you're not crazy about. So just a little plug, if you do go on our webpage and there's a video that kind of, it's like 5 minutes that gives you a rundown, a little more detail than I did about ECHO and how it came to be, you're going to see a number of people. I love this video. On that video that I know, I used to work with them when I was in New Mexico. I worked in a community called Silver City. Bayard, New Mexico was kind of a little sister community to us. And a number of those people I work with, and actually one of those individuals delivered my second child. So just for that reason, go and check out the video on our webpage. These are some of the questions that you guys are going to see on your evaluation. Please do it and pick it. So which of these statements matches your feelings regarding case presentations? If they keep asking for cases, I'm going to quit coming. That may be where you are. I want to know that. I will not cross you off the list, like don't invite them again. I want to know if this incessant, like, please give us your cases, is just like, guys, it's wearing me out. Or if you're there really like the didactic, that's it. That's what I want. I like the didactic and the conversation that generates. That's really great for me. I want to know that. I really enjoy hearing the cases when they've happened and getting the recommendations. If that's where you land, I want to know that. So please go in to your evaluation and answer those questions. And then these are 3 separate questions when you go into the evaluation. Like, I understand how to submit a case, like I got it, or I really don't. It doesn't seem very straightforward. I'm eager to submit a case. I hope it's true after today's presentation, but if it's not true, I also want to know that. And very much on the, I don't care if you pay me, I'm never submitting a case. Also want to know about that. So just getting a sense of where you guys are with case presentations and what we can do to help you feel more comfortable coming forward with the case. These are my